This continuing education event is on the art and science of pain management. What is it? The objectives for this lesson are to describe basic principles of pain management, to demonstrate increased understanding of the opioid crisis by being able to identify 3 causes and describe 2 potential consequences, and to relate 2 reasons why the opioid crisis has increased incidences of elder injustice, and then to identify at least 2 evidence-based alternative pharmacological and non-pharmacological treatments for pain, other than opioids. Pain is the most prevalent problem in healthcare. Opioid use for acute pain is associated with long-term opioid use. Opioids are increasingly relied upon, yet no improvement in pain. There's opioid-centric practices which are not evidence-based. Opioids are modestly better than placebos and no better than NSAIDs. Opioids have strong psychotherapeutic effect. Since 1999, opioid prescriptions have quadrupled. A 300% increase in reported opioid abuse is found, and substance abuse admissions have increased 4 times. Annual opioid-related deaths in Michigan have tripled during this time. We must treat pain, but be aware of the opioid crisis. Pain, as the most common condition in healthcare, leads to ineffective pain management, which can cause a marked decrease in the desirable clinical and psychological outcomes in patients' overall quality of life. Poorly treated acute pain often manifests to chronic pain, over 3 months of pain, and becomes difficult to treat. Over 100 million individuals suffer from chronic pain each day. Patients often prescribed opioids for chronic pain by primary care providers, which then leads to opioid dependence. There are many barriers to pain management. Care providers are one because they have inadequate education in pain management, and they have fears and myths about pain and opioid analgesics, and also an inadequate follow-up process. Another problem is with participants and caregivers. They also have myths about the inevitability of pain, particularly in older adults, cultural and religious issues, and also social and economic factors. And in all health systems, just like my choice, there's a lack of standards in pain control and a lack of specialized pain management resources. Right now, there's a significant effort to decrease reliance on opioids. There's current recommendations from the American College of ED Physicians and the Society of Anesthesiologists on pain management, the Joint Commission, and Institute for Clinical Systems Improvement, which suggest multimodal analgesia, which is combining 2 or more analgesics with different mechanisms of action to produce a synergistic pain relief. Here's the neurophysiology of pain and analgesia. There are 2 well-recognized broad categories of pain: the commonsensical sort, the pain of damage, and the somewhat more exotic kind that comes from damage to the system that reports and interprets damage, the nervous system. It's the difference between engine trouble and the trouble that the light on your dashboard that says there's engine trouble. First, nociception, or transduction, which is conversion of noxious stimuli into nerve impulses via nociceptors. Or tissue damage causes release of excretory substances. This is called inflammatory soup from prostaglandins, bradykinin, substance P, serotonin, and histamine. Inflammatory soup activates the nociceptors. and transmission problems, where the nerve impulse from nociceptor is transmitted from the PNS to the CNS, peripheral nervous system to the central nervous system. And perception, which is the end result of pain transmission. Conscious awareness of pain. It activates higher brain structures in the thalamus and limbic system. And modulation, which is inhibitory responses to nociception. This is how it works. A, nociception transmission, to B, to nociceptive inhibition in C. And then there's neuropathic pain. It's the dysfunction of the PNS or CNS nociception. Possible causes are nerve damage, peripheral and central sensitization like hyperalgesia or allodynia, and suppression of modulatory pathways. There's also other pain. Historically, it's often been called functional pain disorders, which is a terrible name with a lot of baggage. And examples of these are fibromyalgia, complex regional pain syndromes, nonspecific chronic low back pain, primary unexplained headaches, irritable bowel syndrome, other chronic visceral pain disorders, and conditions that begin as nociceptive pain like osteoarthritis, but then go into a downward spiral of sensitization. So what about multimodal analgesia? The transduction of anti-inflammatory medications like NSAIDs, and steroids, and anticonvulsants, which inhibit the influx, and sodium channel blockers like lidocaine and fluoxetine. And transmission, which is the anesthetics of local and regional anticonvulsants, or NMDA antagonists like ketamine. And there's perception of cognitive behavioral therapy and opioids, which impact perception, and modulation, which is through opioids, CNS depressants like benzodiazepines and barbiturates, antidepressants like SSRIs and SNRIs, acetaminophen, and cannabinoids. So there's 4 different types of multimodal analgesia: transduction, transmission, perception, and modulation. So let's talk about the opioid crisis. What is it? It's the increased use of opioid prescription or heroin that's led to high numbers of opioid-related deaths in the U.S. This number continues to rise, with over 64,000 in 2017. The U.S. government declared a crisis in 2017, and more than 130 people die every day from opioid overdose. So why do people turn to opioids? The recent evidence shows 4 in 12,000 had signs of addiction in their medical chart. Meanwhile, in 1996, OxyContin was advertised as less addictive. WHO pain ladder has always been used for a long period of time, which is 3 steps. Step 1, non-opioid treatment. Step 2, weak opioid for mild or moderate pain. And step 3, strong opioid for moderate to severe pain, which then leads to pain control. However, it's based on expert opinion, not evidence. And pain is undertreated. There are initiatives like Pain is the Fifth Vital Sign, and a few years back, My Choice began assessing levels of pain. Joint Commission pain standards were established in 2001. However, the causes of the opioid crisis are that in the late 1990s, pharmaceutical companies assured the medical community that patients would not become addicted to prescription opioid pain relievers, so healthcare providers began to prescribe them at greater rates. Providers were pressured to treat pain as the fifth vital sign and completely take away patients' pain. This subsequently led to widespread diversion and misuse of these medications before it became clear that these medications could indeed be highly addictive. Remember, pain is the most common reason people in the U.S. seek health care and is the primary cause of disability in the U.S. Most common areas of chronic pain are back pain, headaches or migraines, and arthritis. Due to this, opioids are one of the most commonly prescribed class of meds in both inpatient and outpatient settings. Patient satisfaction with care is one of the pillars of patient-centered care and is tied to reimbursement. Also, a portion of physicians' compensation may depend on the quality of services provided, part of which may be based on patient satisfaction targets. I was satisfied with the way my doctor treated my pain is a common patient survey question. To keep patient satisfaction scores up, providers continue to prescribe opioids for pain management. Here's a list of common opioid medications: codeine, fentanyl, hydrocodone, hydrocodone acetaminophen, hydromorphone, mepridine, methadone, morphine, oxycodone, and oxycodone with acetaminophen. So what do we know? Roughly 21 to 29% of patients prescribed opioids for chronic pain misuse them. Between 8 and 12% of patients prescribed opioids eventually develop an opioid disorder. An estimated 4 to 6% of patients who misuse prescription opioids transition to heroin. Despite little change in self-reported pain prevalence since 1999, opioid prescriptions have nearly quadrupled in the U.S. And also, there's elder injustice. Increased evidence that older adults experiencing abuse is rising because the opioid crisis brings them into contact with family members and caregivers desperate to find opioids or resources to buy the drugs. Directly or inadvertently, older adults may be stripped of resources and quality of life because of the struggles of those around them and may be highly susceptible to elder abuse. This is a sub-crisis within the opioid crisis that has not been adequately addressed. In late 2017, researchers from Virginia Tech and the Elder Justice Coalition conducted 4 one-hour focus group interviews with 20 representatives from stakeholder groups in states and counties where deaths from opioids were the highest. The goal of the project was to investigate whether the relationship between high rates of opioid use and elder abuse was a real problem on the ground, its scope, and what the data showed. Overall, focus group participants reported that the problem is escalating in scope and severity. Elder financial exploitation was the predominant form of abuse. Participants also indicated that when desperate perpetrators had gone through the money, the drugs or both, and older adults were physiologically and physically abused. Their abusers isolated the older adult in their own homes so that they could not reach out to others to help them. The focus group findings revealed that the problem is not just limited to home settings. Participants also reported that older adults are being exploited in facility settings, including hospice and nursing homes. In Kentucky, a grandson who had a heroin addiction went to live with his elderly grandfather. The grandfather had a diagnosis of dementia, and the grandson exploited the grandfather for money, around $85,000, to support his heroin addiction. The grandson was taking money out of the grandfather's debit card, writing checks to his friends, and opening credit cards in his grandfather's name, all in an effort to support his addiction. The focus group participants strongly believe that the opioid crisis is contributing to cases of elder abuse. Across the 4 groups, participants stated that the problem is increasing in severity, an estimated 25 to 35% increase in drug-related exploitation cases. And they stressed that there is a dangerous lack of resources to help with drug-related cases of elder abuse, and confirmed there is no reliable, retrievable data to document the scope of the problem across states. What can you do? You need to assess for depression and anxiety, changes in mood, family dynamics, lack of hygiene, inadequately explained or unusual locations for skin abrasions, lacerations, bruises, and burns, spiral fractures of long bones, and fractures at other sites other than the wrist, hip, or vertebrae, in a non-alcoholic elderly person, and also for malnutrition and dehydration. One tool you can use is something like the Elder Abuse Suspicion Index. You also need to think about risk factors: cognitive impairment, behavioral problems, functional dependence, poor physical health, low income, ethnicity. There's increased risk among non-whites for overall abuse and African Americans for financial abuse. If you expect elder injustice in the forms of abuse, neglect, or exploitation, you need to contact Adult Protective Services. So back to pain again. Here are some new guidelines for pain management. Scientists are beginning to challenge the opinion that opioids are the only effective treatment for chronic pain. A new approach is focused on alleviating the causes of the noxious stimuli. The most common classifications of pain are nociceptive, neuropathic, and inflammatory. Each classification causes pain through a unique mechanism and therefore needs a different approach to reduce the painful stimuli. Pain is most often multifactorial, meaning the pain sensation is a product of more than one mechanism and should be treated as such. CDC guidelines include non-pharmacological therapy and non-opioid pharmacological therapy are preferred for chronic pain and should be used first before opioid therapy is started. Clinicians should consider opioid therapy only if expected benefits for both pain and function are anticipated to outweigh risk to the person. If opioids are used, they should be combined with non-pharmacological therapy and non-opioid pharmacological therapy as appropriate. Opioids should not be considered first-line or routine therapy for chronic pain outside of active cancer, palliative, and end-of-life care, given small to moderate short-term benefits, uncertain long-term benefits, and potential for serious harm. So here are a few pharmacological approaches. Using the multimodal analgesia approach, an alternative to opioids for treatment, is this multimodal analgesia approach. It's the combining of 2 or more agents with different mechanisms of analgesia to produce a synergistic effect on pain relief. A multimodal regimen could be tailored to the individual, mechanisms causing the pain, side effects of the meds, and the person's pre-existing medical and psychological conditions. Multimodal analgesia has the potential to relieve pain via various mechanisms by optimizing dosages of separate agents to produce the maximum efficiency while minimizing side effects that can occur when relying on a high-dose single analgesic. 5 meta-analyses determined an opioid plus a non-opioid achieved greater than 50% reduction in pain, significantly more than the non-opioid alone. 1 meta-analysis determined oxycodone plus ibuprofen achieved greater than 50% reduction in pain, significantly more than oxycodone alone. 2 meta-analysis determined acetaminophen plus ibuprofen achieved greater than 50% reduction in pain, more than ibuprofen alone. And one determined acetaminophen plus ibuprofen achieved greater than 50% reduction in pain, more than acetaminophen alone. All of these demonstrate that a multimodal approach is the most effective. Non-opioid therapy includes NSAIDs like ibuprofen, acetaminophen, anticonvulsants, SNRIs, topical analgesics, and a combination of the above where appropriate. Non-pharmacological approaches are highly effective also. Often known as complementary and alternative medicine, or CAM, CAM includes treatments that are used with standard medical treatments but are not considered to be standard treatment, like using acupuncture to lessen chronic pain levels in addition to opioids. It emphasizes a holistic, individualized, and empowering therapy option for patients that is often used for pain management in healthcare and may be used in addition to non-opioid pharmacological therapy and opioid therapy. Some examples include acupuncture, massage therapy, heat and ice therapy, yoga, chiropractic medicine, and low-intensity exercise. One study showed the effect of opioid use plus CAM impacted and reduced chronic pain levels. 42% had a reduced dosage of opioid medication, and 19% actually stopped taking opioids over a 6-month time period. CAM included education about non-pharmacological methods for pain management, guided imagery, relaxation, yoga, exercise, PT, and chiropractic medicine. Of the 42 patients who used only opioid medications for chronic pain, none had opioid-reduced usage, but they did have an increased opioid dosage after 2 years. For RNs and caregivers, if the participant is taking an opioid, determine why, for how long, what dosage, and what alternatives they take. Encourage the use of non-opioid medication for acute and chronic pain. Educate the participant why opioids are not first line and on the efficacy of a multimodal therapy using non-opioid medications. If a patient is on an opioid, remember to educate them about medication safety. Medication safety is a problem for families and especially forgetful older adults. Ensure all meds are locked in a safe place that cannot be accidentally accessed or found to avoid accidental ingestion. Avoid purses, nightstands, and unlocked medicine cabinets. Assess for med safety each visit and educate on the importance of it. Medication review with frequent transitions and care is another critical issue in pain management. Each home visit, go through the participant's medication list, including the drug name, dose, frequency, and route, and compare to the list from the primary care provider, specialty provider, and any hospital discharge orders. It is important that the participant is taking the correct medication in the way that it was prescribed. And we need to think about bringing back balance to analgesia. We know people are now opioid phobic, and before they were opioid centric. And one solution is the multimodal approach discussed in this lesson. Remember, effective pain management is important. Opioid abuse is a significant problem in the U.S. and has resulted in thousands of unnecessary overdoses and deaths each year. Opioids are not the only medication effective at treating pain. Evidence shows that using pharmacological alternatives such as ibuprofen or acetaminophen alone or in combination is efficacious at treating pain. And CAM, complementary and alternative medication, is also effective at treating pain. Educate the participant about pain management alternatives other than opioids and work with the participant in a patient-centered approach to their pain management and educate them about medication safety. And always assess for incidences of elder abuse during participant visits. Here are the references for this program. Thank you for listening.